Dear colleagues, dear friends, this is Nicolas Brogly speaking from Madrid, Spain. First, I would like to thank the organizers of the Congress for this kind invitation, and especially Ruslan Tkachenko for his kind invitation. Today, I'm going to talk to you about an update for the management of severe postpartum hemorrhage, how to decrease the incidence and treat evitable severe complications of delivery related to postpartum hemorrhage. These are my conflicts of interest. And to treat this very important and interesting topic, I chose to divide the presentation in 4 chapters. First, the diagnosis of postpartum hemorrhage, then the initial control of hemorrhage. We will talk also about the treatment of coagulopathy, and then about protocols and existing guidelines in the literature, which I hope will help you improve the management of your bleeding patients. As a reminder, in the world, postpartum hemorrhage is the first cause of uh, death worldwide, while you can see here in Northern America and Europe that it remains among the 3 first causes of postpartum hemorrhage, of death um, in the context of delivery. As you can see, 27% of women die of postpartum hemorrhage, and this is largely preventable. This means that we can act and we can try to reduce this maternal mortality cause. When you first want to act on that, you have to know exactly what is a postpartum hemorrhage. And this is why it is so important that you estimate properly your blood losses. In the past, we used to use visual estimations, but this is a historical method which still is used in some cases, but which underestimates significant blood losses and also overestimates low blood losses. So it's not so precise. To improve the precision, some quantitative estimations were developed, and now we talk about gravimetric measurements, which weigh the surgical fields and the gauzes, and so allows us a lot more precise measurement of blood losses, but also volumetric methods in which you just measure the volume of blood which has been uh, seen in this uh, postpartum hemorrhage women. An important measure is to see also what we consider over bleeding over the normal values. And for that, you usually consider that a postpartum hemorrhage is seen for a vaginal birth above 500 milliliters of blood loss, and for cesarean section for blood loss above 1000 milliliters. You can also see that a PPH is severe in case that you have higher blood loss volumes and when this hemorrhage is associated with signs of hypovolemia or also with signs of coagulopathy. There are some signs of alert for severe postpartum hemorrhage, which includes hemodynamic changes, tachycardia, hypotension, but also hematologic, paler drops in hemoglobin values, and metabolic also, like lactate, shock index also in the hemodynamic, and repercussion on volemia, on neurological exploration, and also coagulopathy. In that case, it is important that if you detect some of those signs of alert, you act because patient is not going to be well, and the faster we act, the better the prognosis will be for the woman. One of the parameters which has been studied very recently is the shock index. And when you use this shock index in this study published this year, you can see that you have a good predictive value for refractory postpartum hemorrhage, which means that if you use this shock index to treat the patient, maybe you will have better results also on maternal outcome. It is true that is not so discriminating, but it is useful because it is very inexpensive and very easy to calculate. Now you have done a good diagnosis of your PPH. You know it's whether it is severe or not, it's important to start controlling the hemorrhage. And before you control it, you will start resuscitating the patient. Be aware that the fluid therapy volume you use is very important. If you do a massive reposition of fluids using crystalloids and colloids, you might have higher rates of maternal complications. If the blood reposition with crystalloids or colloids is above 4 to 5 liters, you increase the rate of maternal complications by 1.8. If you administer more than 5 liters to the patient, then you will multiply by 4 the risk of maternal complications. More or less the same also for the risk of coagulopathy. If you administer more than 3.5 liters and of crystalloids and colloids in a bleeding patient, you will start to see some platelet count alterations, fibrinogen decrease, APTT and PT alterations, which will cause a real problem for the coagulopathy. This is why the Royal College of Obstetricians and Gynecologists recommend that you do not administer more than 3,500 milliliters of fluids before you start transfusing blood because of the risk of dilutional coagulopathy and maternal complications. It's important also that you remind the 4 causes of postpartum hemorrhage: tone, trauma, tissue, and thrombing, being the uterus atony, the first cause and the first to treat. This is why the eutonic drugs are the first-line treatment in case of postpartum hemorrhage. And you could, I don't have much time to remind you, but there's a consensus of the use of uterine agents, being the oxytocin, the first-line treatment, which it is recommended that you associate with other lines of treatment very rapidly if you don't obtain an adequate uterine contraction using ergometrin. Carbetocin is an alternative option to oxytocin because it has a longer duration of action. And oxytocin can also be associated with prostaglandins, with misoprostol, which will also decrease the risk of maintained atony. In case medical treatment is not useful, an implementation of intra-uterine balloon tamponade was implemented in many units and has improved a lot maternal treatment for uterine atony, and actually it is associated with a significant reduction in the rate of invasive procedures related to PPH, such as uterine artery ligation, compression sutures, hysterectomy, and arterial embolization. And if it is inserted very early in the management, it will also avoid further complications to the mothers. In case of predictive hemorrhage, some intravascular devices like the resuscitative endovascular balloon occlusion of the aorta devices have allowed also to decrease the risk of severe hemorrhage, especially in case of placenta accreta spectrum. It is a very useful tool, and we recently published in EGA a series of 47 cases which were used in several hospitals in 4 hospitals in Europe. So it's a very, very interesting tool to start using if you don't have it in your hospital, although it is necessary to have really multidisciplinary team, including also often some interventional radiologists, which should be available for you. Now that we have treated really the hemorrhage, control the blood loss, it's important to know that sometimes coagulopathy occur, and it's important also that you know how to treat that. First of all, it's important to detect when a patient is at risk of coagulopathy, and the risk of coagulopathy increases significantly when the blood loss is superior to 1,500 milliliters, for which 23% of parturients will develop this coagulopathy. There are also some associated risk factors like hemodilution, like tissue problems in the causes of the hemorrhage and trauma. The typical cause is amniotic fluid embolism, which is often associated with coagulopathy. An important feature also is treating adequately the associated factors of coagulopathy, which are hypothermia, acidosis, and also hypocalcemia. So we were talking before about the triad, deadly triad. Now we have the deadly diamond, and they also talked about the deadly pentad, which could be treated to try to improve the patient's prognosis. But the first stage of coagulopathy treatment is to prevent it and to avoid its development from the very, very beginning. Tranexamic acid has demonstrated that when it's administered in the first 3 hours of the postpartum hemorrhage, it can decrease significantly maternal mortality. In this systematic review, including the 2 women and the 2 TRAP studies, what you can see is that you decrease by 23% the risk of mortality after PPH if you use tranexamic acid. However, this effect on mortality is not modified neither by prepartum risk of bleeding or the type of delivery, the presence of absence of anemia, and overall the preventive or therapeutic administration of tranexamic acid, which means that you don't gain so much if you give it preventively versus a therapeutic administration when PPH has already started. The drawback of tranexamic acid might be this risk or theoretical risk of thrombotic events. In this meta-analysis, they tested also the risk of thrombotic events and did not find any risk. I mean, there's not an odds ratio which would suggest that tranexamic acid is associated with a higher risk of thrombotic events. So it is a safe drug to use for also the risk of thrombotic events. As a conclusion, the authors say that the overall mortality decrease by the use of tranexamic acid is real, but the benefit of prophylactic administration, is to be discussed on a case-by-case basis, depending on really risk of bleeding in patients who would have a real high risk of postpartum hemorrhage. Another treatment which can be interesting is the introduction of calcium, which is implicated in uterine contraction and also in the coagulation. In this study, they gave 1 gram of calcium after the clumping of the umbilical cord in women submitted to a cesarean delivery, and they found that when they adjusted their results on blood loss, there was a significant decrease in blood loss in the group receiving calcium. No side effect was reported in this study, so this could be an interesting point to implement in our protocols for PPH management, is the administration of calcium chloride, because it has an interesting uterotonic property. And this can be useful in the treatment of postpartum hemorrhage because it has low price, very few side effects, and is very easy to access. Concerning the use of prophylaxis, empiric of fibrinogen, there has been lots of literature about that, but we can stay with this conclusion that if you give it in a patient who has a high level of prepartum fibrinogen, you will not have any benefit on blood loss, transfusion requirements, and postpartum anemia. So fibrinogen concentrates can be administered, but not as a prophylactic treatment. As a summary, tranexamic acid is very interesting. Transfusion of red blood cell concentrates, fresh frozen platelets, plasma and platelets should be guided. Fibrinogen should be guided, and you have some second-line treatments as prothrombinic complex concentrates and maybe some recombinant factor 7 which is not defined for its indication right now. What is very important in the last 5 years is the implementation of protocols of guided therapy for prothrombinic drugs and the use of viscoelastic tests. The Cardiff team implanted in their hospitals the use of ROTEM or TEG viscoelastic tests, which help them to see whether there is a deficit in fibrinogen. FibTEM-A5 inferior to 11 millimeters should indicate to us the use of fibrinogen. An XTEM CT superior to 75 seconds should indicate to us also the administration of fresh frozen plasma. Although there is no indication or guidance for the use of platelets based on ROTEM protocols, maybe in the future we will also have some indicators for that in the viscoelastic test results. Now we have been talking about all the measures. It's important to put them all together and make some recommendations. And this panel of experts, European panel of experts, gave us some indications about identification, diagnosis of postpartum hemorrhage, initial treatment, including the early use of tranexamic acids, and then the guidance of our procoagulant treatments based on the results of viscoelastic tests using all these types of measures, but they also give us some guidance on what happens once the PPH is resolved. And it's important that we give some thromboprophylaxis because after the use of pro-thrombotic drugs, there is still a risk that the patient develop some thrombotic events in the postpartum period. And also, it's important that we treat the anemia. When we use some protocols for guiding the fibrinogen, fresh frozen plasma, pro-thrombinic complex, you can see here in this study made in Cardiff that using those protocols of guidance, you decrease progressively the risk of severe postpartum hemorrhage, and you decrease also the number of units of blood which were transfused to patients. So these protocols work and have very positive effects. In France, you can see by this very interesting paper published last year also that they managed to decrease by 65% the mortality, implanting in all the maternal units of the country some new recommendations, new guidances for the management of postpartum hemorrhage. And although they had this very drastic implementation and improvement of maternal mortality, still the remaining deaths were in 88% of the cases evitable, avoidable, which means that we can still make some progress on that, working more on maternal mortality. With very simple measures, in this paper published in New England Journal of Medicine in 2023, you can see that in African countries, low-income countries, applying only early detection, massage of the uterus, oxytocin drugs, tranexamic acid, IV fluid, and examination and escalation, the emotive protocol, they divided by 3 maternal mortality in the period of the protocol. So you can really, with very simple measures, you can decrease significantly maternal mortality. This led also the European Board and College of Obstetrics and Gynecology to publish this editorial this month, in which they define some clinical priorities for PPH management, which should lead us to change our policies in Europe for the management of PPH and implement some system level changes which will really permit us to decrease maternal mortality. To finalize the talk, I wanted to talk to you also about iron deficiency during pregnancy, which really is important. And in fact, if you have normal iron stocks in your body, the parturients will have less chance to develop a severe PPH, will require less blood transfusion, and maybe, and probably, and surely will die with less frequency due to a postpartum hemorrhage. As a take-home message, how to improve PPH management? First, early detection and accurate estimation of blood loss. Second, teamwork and protocols. Then, control the cause, rational use of uterotonics, intrauterine balloon and intra-aortic balloon when it is necessary. Effective resuscitation, normotensive, normothermic, non-acidotic, non-anemic patient is required to maintain that. And a correct hemostatic control using early tranexamic acid, using viscoelastic tests, which will allow us to do some target-guided corrections of coagulopathy. Thank you for your attention. We are expecting you in Rotterdam for your anesthesia congress, and see you very soon. And I am available on this email address if you have any further questions. Thank you for your attention.